Thank you very much for the opportunity to speak and share actually what we do behind the scenes in the lab actually. So not just doing routine work, but we're also trying to understand better to improve diagnostic testing. But also here we often look into the different rare allergies to try and improve the understanding on the scientific level as well. There we're trying actively to collaborate and improve understanding. So why we are talking about this today is because bisphosphonates, they are not so frequently seen in adverse reactions, and we see some interesting patterns in the lab. And so to begin, I will go through the basic pharmacology and where it's used, and also to describe that we use, or in the clinics, it's used at a different range depending which one you use, and also which route of administration. Then, of course, we focus more on the adverse reactions, and then understanding how the pharmacology of the drug influences the immune system, and then showing you results from the lab and coming to a conclusion. So what are bisphosphonates? These are drugs, small molecule drugs, which contain two phosphonate groups. So there's two areas here. And based on this negative charge, they have a very high affinity for calcium. And in the body, the very high deposition of the calcium is really in the bones. So therefore, these drugs are targeted rapidly there. So what is the drug used for? It is used to prevent bone density loss, so osteoporosis, Paget's disease, and in certain cases also bone osteoporosis when it's associated to some metastasis. And the function, I will come into it in the mechanism of the drug, I will come in the next slide to explain. What's going on? Yeah. So here I give you 3 different examples of bisphosphonates. So what I want to highlight to you is that you can have different routes of administration. So there are those which you give orally, those that are mostly given orally, but sometimes very specifically, maybe into like knee area, so you have intravenous infusion, or also one that's really purely intravenous, so zoledronate. And what is important to note here is that the Cmax, the maximum concentration in the plasma, can be very, what's going on? Can be very variable, dependent on which bisphosphonate is used, and also dependent on the oral, the route of administration. So here you have 160 nanogram per milliliter in the Cmax, but then here for ivandronate, we have both oral and IV routes of administration. You see that, of course, the IV has a higher Cmax. And zoledronate then has the highest. And also, clinically, it is used at a higher dose. So bear that in mind. And so I want to talk again now really on the mechanism of action of these bisphosphonates. And so I've mentioned before that they have a high affinity for the calcium in the bones, and they go there rapidly. And what they do there is really inhibit the recruitment and also induce apoptosis of osteoclasts. And these osteoclasts are actually important in resorption and of the bones to help you remodel. But specifically, the bisphosphonates are blocking the farnesyl disphosphate synthase enzyme. This is found in all cells, actually, but because they are found really in the bones, it's more affecting the osteoclasts. And this pathway here is very important because this mevalonate pathway, it's finally leading up to the formation of cholesterol and isoprenylated G proteins, which are very critical for the formation of cell membranes. So here you're actually coming in with the bisphosphonate, inhibiting this part, and therefore not allowing the cholesterol and other critical lipids to form to help support osteoclast formation. So therefore, what ultimately happens is that your osteoclasts are inhibited, and therefore your bones are kept they're prevented from being resorbed, and therefore you have less bone turnover, helping then the osteoporosis patients. So why is it important? Yeah, the computer is froze. All right, there we go. That's not me moving it, it's just now lagging. Okay. Can I get some assistance here, please? I think it crashed.
Just now?
Or it's very laggy, or...
Yeah. So sorry. Still recording, nice. We'll just try again.
Yeah.
Just hold on for a second.
Yes. So just going through this pathway here, why is it important? Because actually, sorry, coming back first now to adverse reactions. So I mentioned before that the administration route and the dose is important. And what we also have noticed before is that the most common symptom is actually rather gastrointestinal symptoms. So abdominal pain, nausea, and diarrhea. And there you often see them with more the oral given bisphosphonates. There is probably because the drug is actually causing some irritation, and maybe the drug was not taken in the right instructions. And then when you look into infusion reactions and flu-like symptoms, this is then, of course, really more with those IV administered drugs, and they are typically appearing within 3 days of the infusion. And also, skin rashes, these are much more prevalent when you have those administered IV rather than orally. And our understanding of rashes or exanthems is that you can see that when you investigate into the lesions of the skin histologically, you can see T-cell infiltrations, and then the presence also of cytokines, including, for example, interferon gamma, IL-5, and cytotoxic granules. In the case of bisphosphonates, however, there may be an interesting role of gamma delta T cells. And these are just unconventional T cells, and I come now back to this because it's quite an important relationship here. So when we have the bisphosphonates, which inhibits your the synthesis here, you start to have a build-up of these phosphoantigens, and these phosphoantigens has been shown to bind intracellularly to this butyrophilin molecule that's found on basically all cells. In normal physiological conditions, this is a stress mechanism of the cell to induce, to alert of a stress or damage in the cell and target it for being killed. And the consequence of these phosphoantigens being bound to butyrophilin is that they can actually activate the gamma delta T cells, particularly this V gamma 9 V delta 2, which is actually not too rarely found circulating in the blood, in the range of 5% or so. And when these cells are then activated, they can induce cytotoxicity and also release cytokines, including interferon gamma and cytotoxic granules. Thank you very much. Yes. So then, because of this association of the gamma delta T cells and how the bisphosphonates here are creating this buildup of phosphoantigens, the question is then, when you assess this in the Cyto-LTT, will we always have a positivity of interferon gamma and granzyme B in all patients when we test for bisphosphonates? So here we show the results in ADR-AC. So we had 14 different patients evaluated here, meaning those that were tested for zoledronate and also other bisphosphonates at the same time. And here I'm showing the data to zoledronate because this is the IV administered one. And what we do indeed observe is that there's many times where we observe strong interferon gamma and cytotoxic granules secreted, which does fit with the gamma delta T cells activation. So here you see a lot of activation for interferon gamma particularly and granzyme B. However, there are some patients that have rather a mixed cytokine response. So again, you do see mostly activation of gamma interferon and granzyme, but also high IL-5, IL-13 cytokine secretion. So these patients may actually, and this is to show you that, again, we test to show that there's no unspecific responses. It's not that every patient responds so strongly. But focusing a bit here now, this IL-5, IL-13 response may show that there's involvement of other CD4, CD8 T cells. And importantly is to reflect back onto the clinical picture. And we heard today about eosinophilia and how there's a change in the IL-5 signalosome. So maybe that could be something to explain why we see this here. So hypersensitivity induced by other T cells. And this one's with the high interferon gamma, granzyme B, may indeed be more reflective of the gamma delta T cells that are activated. And we need to better understand the clinical picture of these patients here versus these patients. If these ones here mostly had really exanthems, and if these ones here had some eosinophilia and other potential other organ involvement. Indeed. So what about the other bisphosphonates? Here, I'm trying to highlight to you that the concentration range is important again. So remembering that we have these 3 different types of bisphosphonates, alendronate orally given, so lower Cmax, and the zoledronate, which is the IV, and higher Cmax. I first show you the results of those with a strong interferon gamma and granzyme B reaction. So here you've seen this on this side already before, a strong dominance of interferon gamma and granzyme. But we don't see this response really in the ibandronate and also the alendronate responses. So even though they affect the same pathway, it does not seem to have a very strong effect, and that may be due to how we don't test it at such a high concentration in these two molecules, but that is dependent on the Cmax. And when we look into the IL-5, IL-13 response, again, we've seen this one before, the zoledronate response, but you also see some here more in the ibandronate and not so many than in the alendronate. So here highlighting that it's important to consider what your Cmax is of your drug and to also consider what types of concentration range you test in the Cyto-LTT. So then concluding this, I show you here that bisphosphonates influence the activation of gamma delta T cells. And others have actually shown that if you isolate gamma delta T cells and expand them in vitro, you can actually induce, so these are individuals who have never been exposed to bisphosphonates, you can actually still activate them with the bisphosphonates in vitro. And indeed, it's important to consider plasma max concentrations and how this influences your reactivity of your cells in the Cyto-LTT. And those patients where we see a strong interferon gamma and granzyme B secretion, this may be due to rather the gamma delta T cells influence that we see in the Cyto-LTT. And of course, then the question is this a false positive, or is this rather linked to the clinical picture? And this is open up to discussion still, actually, because we observe this. We see this high positivity rate. We're sharing this information with you, but then we don't always have the full, complete picture of the clinic. So this is where feedback also with the clinicians helps us to understand whether some result is a false positive, which we don't believe here because we see some negative results too. But actually, is it more important to link this diagnostic result back to the clinical picture? So exanthems versus stress, for example. And indeed, again, with the IL-5, IL-13, is that more showing you eosinophilia involvement or stress? So thank you very much. That's me.
Thank you very much, Lasse. Are there any questions? complicated, but there are not many reports about gamma delta T cells and drug hypersensitivity, actually. It's very, very rare. Also, they play a big role, gamma delta T cells, in immunity. But you see, we still study something and learn something. Maybe if you have nice cases, tell us.
Exactly. The point of sharing this is to share that we are doing a lot of research work behind the scenes too. And it's not just to get a good result, but to understand the science behind it.
No?
Merci. Lester, do we have some symptoms of these different patients that we can see perhaps a comparison between your data and the symptoms?
Yes, so this is what I mean. It's important that it's really, so also advertising here, please fill in the clinical diagnosis in the forms. It really helps us to better understand the picture as well. In this limited sample of 4 patients with the mixed cytokine response, 2 of them actually did have more eosinophilia. So there's maybe a link there to this IL-5 response.
Okay.
But yes.